It is my pleasure to introduce our bariatric surgeon, Mark Kovler. I'm very excited to have him come and speak with you. And just to let you know, we work very collaboratively together, and it's been wonderful to have Mark on the team.
Okay, thank you. Thank you, Dr. Vaidya. It's a pleasure to be here. My name is Mark Kovler. I'm a pediatric surgeon at Children's Hospital and practice the full depth and breadth of pediatric surgery, but I'm here today to talk to you about a special part of our practice in which I'm the director of the Pediatric and Adolescent Bariatric Surgery Program. So several objectives today, but mostly I want to talk to you about bariatric surgery for adolescent patients, describe to you some of the indications and preoperative planning and assessment for those patients, and then demystify the surgery a little bit for you all. Just tell you what it's like, how long it lasts, what the recovery period is like, so that you can bring this up to your patients and feel comfortable answering some of their preliminary questions in your clinics. And then go over the outcomes and potential complications and things to look out for, and then introduce you to our team and how to get your patients referred to our bariatric surgery program. So why are we even entertaining this question? Well, you all know this from your practices, but obesity in adolescents and teenagers is increasing in prevalence. This shows the past several decades national data. More than 1 in 5 patients who come into a pediatric practice are going to be diagnosed with obesity. And the types of obesity that we're seeing in our medical and surgical obesity clinic, class 2 and class 3 obesity, has actually doubled in the past 2 decades. Because this is a regional conference, I wanted to hit home a little bit, maybe spark some competition amongst the different providers here. DC is not doing well. We are ranked 43rd in the prevalence of pediatric obesity, with 35% of our patients considered either overweight or obese. Virginia is a little bit better, somewhere in the middle of the states with 27th, and Maryland is the least prevalence at 16th. So you all can help your communities by referring your patients for obesity treatment, both medical and surgical. But for your individual patients, this is what really hits close to home for those of us who are taking care of them. And that is that children with obesity become adults with chronic diseases. So you're seeing children who are big and starting to see some of the comorbidities associated with obesity, maybe early insulin resistance, some type 2 diabetes, a lot of patients with obstructive sleep apnea. You're definitely seeing depression and social stigma related to obesity, and some patients even have liver disease developing already. So I spend most of my training on adults, doing surgery on adults, and when you see 40, 50 years of this cumulative chronic diseases occurring, things get to be very ugly. You start to have end organ damage from these, cirrhosis with the need for liver transplants, dialysis patients, vascular patients needing amputations, end-stage heart disease, premature cancers. And I really want to empower you all that you can help your patient for the rest of their lifetime by disrupting this progression from childhood and teenage comorbidities to chronic adult diseases. There are many options for treatment of obesity to stop this progression, and we're all practicing all of them every day. I think you all are probably frustratingly somewhat limited in your practices in lifestyle and modifications and diet programs. And that's what Dr. Vaidya and I are here to do today, is to open up the ground for more effective treatments, to put them both in your practices, but also in your referral patterns. So once you get to class 2 or 3 obesity, BMIs of 35 and 40, the chances of losing significant amount of weight in a sustainable fashion through lifestyle modifications and diet programs is very little. And that becomes very frustrating for the patients, for their families, and for you all as the frontline providers. Pharmacotherapy is becoming more effective, thankfully, and in 5 or 10 years, maybe there will be no need for this talk, and I'd be happy with that. But right now, bariatric surgery remains the most effective, durable treatment that is well studied in long-term studies for severe pediatric obesity. I want to dive into the indications a little bit, and these come from the 2023 AAP guidelines, practice guidelines on the evaluation and treatment of children and adolescents with obesity. This guideline really changed the paradigm of bariatric surgery being a treatment of absolute last resort to being a part of the standard treatment algorithm for pediatric obesity. The guidelines, and there's a QR code for the guideline. If there's one thing you should take home from this, it's the bullet points from the AAP guideline, is that your patients who are 13 years and older with severe class 2 and class 3 obesity should be at least offered a referral for bariatric surgery evaluation. Class 2 and 3 obesity, I know you guys see this every day, but the easy ways to remember it, class 2 is BMI of 35 to 40, and then they will qualify for bariatric surgery if they have a weight-related comorbidity. Or class 3 obesity, a BMI of greater than 40, regardless of their other health problems. Because BMI, we all know, is not a perfect indicator of metabolic function and excess weight in pediatric patients, we also allow for a BMI percentile above the 95th percentile. It's very complicated to calculate. I recommend just putting into ChatGPT, what is the 95th, 120% of the 95th percentile for a 16-year-old female? And it will tell you. So these are the patients that you might want to consider offering a referral to a bariatric surgery center or to the Ideal Clinic. The surgery that we perform is called a laparoscopic sleeve gastrectomy. This surgery is performed almost exclusively in adolescent patients and makes up about 80% of the bariatric surgeries occurring in the United States in adults. It's a minimally invasive surgery. We perform the surgery through 5 small keyhole incisions. The surgery takes about an hour or less. And during the surgery, we remove 80% or so of the stomach, stapling it off using a surgical stapler and removing the part that's along the greater curve. And you're left with this thin sleeve of stomach, which is why we call it a sleeve gastrectomy. This does 2 things. The surgery works in 2 ways. Number one, it reduces your stomach volume to 20% of the preoperative volume, and that limits how much you can take in. So I talk to the patients beforehand and I tell them, right now you sit down at lunch and you eat a sandwich. Well, after the surgery, you're going to sit down at lunch and you're going to eat 2 or 3 bites of a sandwich and you're going to feel full. And then you're going to eat more frequent small meals throughout the day, but this full eating of a full plate of food is probably not going to be your pattern anymore. The second way the surgery works is hormonal. So this part of the stomach produces ghrelin, which is our hunger hormone, remember from medical school. And this part of the stomach is actually taken out of the body in this surgery, as opposed to some of the other surgeries like gastric bypass. And that reduces a lot of the food, hunger, chatter that goes on in the brains of these children. So that's the surgery. It's actually probably the easiest part of this whole process. Much more time is spent in the medical clinic, taking care of the patients and trying to get insurance approval. The postoperative course is relatively straightforward. Most patients, I'd say 85% of the patients in our program stay in the hospital for 1 night. We don't give them any narcotic pain medication. They just go home on Tylenol and ibuprofen over the counter. And the risk of serious complications, which are basically a leak up from that staple line or bleeding from that staple line, is exceedingly rare, less than 1% in our hands. Patients have their diet advanced from clear liquids to more textured foods, maintaining a protein-based diet over the next month or so. And how about the outcomes? So this slide is a little small for you guys, but I just want to tell you about one study that's been going on for the past 20 years or so called the Teen Lab study, which is run out of Cincinnati, Colorado, and Chicago. And it's been published multiple times in the New England Journal of Medicine. So this is very well studied, very followed up, amazing follow-up for this study. They started out with 100 kids about 20 years ago, and they've had 85% follow-up at 10 years. So it's really terrific. And just want to emphasize that the data is there, that this is very safe and effective. So at 10 years follow-up, patients will see a 20 to 25% reduction in their BMI. So that takes somebody who's a BMI of 40 down to a BMI of 30 to 32. somebody in 35 into the high 20s along the same lines as their surgeon. And the outcomes are very good. Now, I think the outcomes are going to become even more successful. If you see, there is some weight regain here between years 5 and 10. And I think with the effective medications that we're able to prescribe, we will really be able to curb any of this weight regain in our patients further out. The resolution of comorbidities is even more impressive. So half of the patients that come in with basically any of the comorbidities, liver disease, diabetes, hyperlipidemia, are cured of those diseases 10 years after their surgery. And this is about 2 or 3 times more effective than the surgery is when they're adults undergoing the surgery, the rates of remission from these comorbidities. So that's why we really want to get, especially the kids who have comorbidities, into the surgery program sooner so that we can have a more effective treatment for them. I want to introduce you all to the team who's doing the surgeries at Children's National. There's 3 surgeons, myself as the director of the bariatric surgery program, Dr. Michael Petrosian, who's our chief of pediatric general and thoracic surgery, and Tim Kane, who is our recent chief of pediatric general and thoracic surgery. You probably had these folks operate on your patients for other reasons, and we're happy to now offer this surgery. Caitlin Sherman is the program coordinator. She's a nurse practitioner. She's been with the program for over 10 years, and she is the heart and soul of this program. It will be the front-facing person, point of contact for your patients and for you all. Our program has performed over 850 bariatric surgeries since the program launched in 2012. We are the largest, have the highest experience in pediatric bariatric surgery in the United States. We have referrals from around the globe and around the country. And again, we do this in a truly comprehensive, multidisciplinary way, working hand in hand with the IDEAL folks. I often say, if you want to get somebody into IDEAL Clinic and the waiting list is too long, just send them to me. I'll have them in a month. We have in-house psychology, nutrition, and nursing with specialized care in bariatric surgery patients. And at Children's, what we can really do is take care of the complex patients who are requiring bariatric surgery, those with uncontrolled diabetes, neurologic deficits, neurodivergent patients is a big population that we have, and those with genetic predispositions to obesity or obesity-related comorbidities. We've been nationally recognized and have many publications and research endeavors underway. Our hope is to be able to serve your patients in the communities where they live. So we are now having bariatric surgery appointments in Virginia, DC, and Maryland, in the Fairfax office, in 2 sites in Washington, DC, in Friendship Heights, and at our main campus, and then also in Prince George's County. All of the surgeries take place at the main hospital because it requires an overnight stay, but we're able to meet your patients near their homes for follow-up and for continuity of care. So thank you all for taking the time to listen to a surgeon talk about pediatric care. And I'm happy to take any questions or meet you at our table in the exhibitor hall.
Hi, I'm Sarah. I'm an NP with School-Based Health in Montgomery County. I was wondering if you could talk about, I'm sorry. I was wondering if you could talk about how much do you guys work with sort of the plastic surgery that often needs to accompany these surgeries? Because obviously we all know what bothers these kids the most is the social aspect, what it does to their social life. And I've seen a few patients go through the system and then they wind up not feeling that much better about themselves because they have so much excess skin. And so I was wondering, is that a part of what you do? I mean, not you personally, obviously, but like, what's the lead into that? Is there a discussion of that? Anything you can tell me about that would be really helpful.
Yeah, absolutely. So we have a close working relationship with several plastic surgery practices in the area, including our own pediatric plastic surgeons. But for many of these patients who are in their late teens, early 20s, by the time they have reached a plateau of weight, they're ready to go to any community pediatric plastic surgeon to take care of the extra skin. And so we ask the patients not to seek that care until they've really reached a plateau, because I have seen patients in the past who go for skin contouring surgery and then lose more weight, and they're not happy as well. So, I tell them two things. One is don't buy any new clothes for the first 9 months. We're going to be making repeated trips to the store because you're going to keep sizing down. And then the other is to wait usually at least a year or 18 months until we're ready to refer them for contouring surgery. But it is a big part of the care. It's impossible for me to figure out which patients are going to have a lot of extra skin and not. So some patients, especially adolescents, do a remarkable job, their bodies, of recontouring themselves, but some certainly do require operation.